We'll start the session because speakers are there in both F and G halls, so they will be shifting between the two halls. So the order of the presentations will be a little different. Can you put the switch to mine? So these are the topics that we'll be covering. Okay. So going first is Dr. Savri Desai, COVID-associated mucormycosis, first to second wave, the catastrophe.
Raghu for putting this together and Tarjani, and I'm going to be speaking a very quick. मेरा slides क्यों नहीं आ रहा है? I'm going to be speaking on something called as COVID-19 associated mucormycosis, the first to second wave catastrophe, because we've been seeing mucormycosis for a while now. It's come everywhere, huh? ये इससे मेरा वापस गया. हाँ, okay आया. Okay, so just to put it, so we've been seeing mucormycosis even pre-COVID era, but in the COVID in the first wave, as you can see, the mucormycosis was, not COVID associated, was there, but it was not in these spiraling numbers. And then if you see in the second wave, between April and May, it just went through the roof and it increased. And what was the reason why? So if you just look at this, was a very nice article which compared first and second wave. So firstly, the onset of COVID CAM was within a week of diagnosis, where here it was usually post-recovery. Though the progression was rapid, we could diagnose it early because we were more well informed. But the biggest thing was that while we were doing more exaggerations and there was not much tram in the first wave, we started using much tram, which, Tajani and will be speaking on. In this also, if you see, there are certain more things, is that basically everything, the way the mutation had, the Delta variant, basically everything went up, breathlessness, oxygen requirement, and this further caused a rise in the ROCM cases. These were some of the other things that went up because of, all the other parameters, so which further caused a rise in COVID. And compounding this was the drug crisis, due to which we couldn't get drugs, and because of which, again, a lot of government regulations came in and the surgeries and the drugs got capped, which was good. So basically, aggressive operations such as orbital exaggeration went down, though we were still doing it, and everybody was trying to avoid morbid surgeries, and TRAMB basically took sort of a big boost, and hopefully we've learned a lot from this two waves and won't be seeing more of these. Thank you. That's introduction.
Next, Dr. Namrata will take up the topic of orbital exaggeration, techniques and complications.
A very good morning, everyone. I'm Dr. Namrata Arulkar, and at the outset, I would like to thank RAGHURAJ for this wonderful IC that he has put together, and would like to thank AIOC for the opportunity. I have no financial disclosures. I will be talking on exaggeration in ROCM today. Exaggeration, as we all know, is the most destructive ophthalmic procedure and entails removal of all the contents of the orbit, which includes the orbital fat, extraocular muscles, eyeball and optic nerve, categorized into total, subtotal and radical or extended type. Eyelid sparing is the preferred technique that we use these days. All of us are aware of the indications which primarily includes the malignancies, extensive primary orbital malignancies, intraocular malignancies with extrascleral invasion, malignant eyelid and adnexal tumors with intraorbital spread, and sometimes life-threatening invasive orbital infections like the one at hand here is mucormycosis. Now coming to indications of exaggeration in ROCM, mainly based on clinical presentations and radiological findings. Now this is a paper from pre-COVID era, and it was a group of ENT surgeons who studied cases of ROCM and concluded that the decision of exaggeration should be based individually on each patient depending on retinal artery involvement, aggressiveness of the disease presentation, type of underlying disease process, response to initial therapy, and the vision of the patient. Another, again, ENT paper which came out from Sion Hospital in Mumbai, and they based their system basically on three components: clinical signs and symptoms, direct and indirect ophthalmological examination, and imaging findings. Each subclass was given mild, moderate, severe rating and and a point of 1, 2, and 3. If the total score was more than 23, the patient was taken up for exaggeration. Quite a simplified objective classification that they gave. Dr. Honavar in 2021 was the first person to give a staging system for ROCM when we've seen this disease in very high numbers, and really left us scrambling all over to know what to do. So he concluded that stage 3C and D patients who have extensive orbital disease were primary candidates for orbital exaggeration. He also said that in patients who are stage 3A to C, if the disease is progressing despite aggressive sinus debridement, systemic antifungal therapy, and transcutaneous amphotericin B, we may consider these patients for exaggeration. In patients whose disease is already spread to the cranial cavity, if their condition permits, surgery may be taken. Now this is a wonderful paper written by Drs. Akshay and Tarjani, and very beautifully they have described the ominous orbital signs which point out towards an aggressive advanced orbital disease. And they give some really objective pointers to considering patients for exaggeration. Now what are these signs? Loss of contrast enhancement. We all know MRI with contrast is a gold standard investigation for patients with ROCM. And loss of contrast enhancement, a term that we all have been hearing again and again, is this is what it means. So here we see classically the loss of contrast enhancement at the orbital apex. Now these are patients in which there is loss of vision clinically. The eye is vision and eye is not salvageable and are good candidates to consider for exaggeration directly. Patients with diffuse loss of contrast enhancement in the orbit and sometimes associated with an intraorbital abscess like here, and diffuse loss of contrast enhancement along with loss of contrast enhancement in the cavernous sinus. Another patient with extensive advanced disease, you can see the black eschar even in the adnexal area in the medial canthus, and this patient had severe globe distortion and what we call as a guitar struck sign along with perineural involvement. So these are indications when you do an exaggeration. It's important to bear in mind that not all patients who are no PL need exaggeration. At the same time, we are not able to salvage all seeing eyes in these patients. It's like retinoblastoma, they say, let them see, first they live, then they see, then they have an eye, and then they see. So similarly, it's important in life-threatening disease like this to consider the case as a whole, not wait till to save a seeing eye. Coming to anesthesia, hypotensive general anesthesia is the preferred anesthesia. However, there has been reports of surgery being performed, one here from LVPI team, in which they did 5 cases under local infiltration anesthesia along with deep sedation, and they reported satisfactory conditions and stable hemodynamics with successful daycare management of patients. It's a good idea to keep a unit of blood grouped and cross-matched ready, although bleeding is quite substantially less compared to the tumor patients that we operate for exaggeration. Hemostatic agents like gel foam and Surgicel is always come in handy during surgery. This is a short surgical video showing eyelid sparing exaggeration. We take three tarsorrhaphies, temporary ones, which act as traction suture. A skin muscle incision is made. Here I am using the monopolar cautery, cutting cautery, is made 4 to 5 millimeter all around the palpebral aperture. A skin muscle flap is raised, and here you see there is some amount of bleeding. The incision is extended, dissection carried all the way up to the orbital rims, all around 360 degrees, to expose the periosteum of the orbital rim. Incision is made in the periosteum at the rim, and periosteum is elevated with a Freer's periosteum elevator. All the orbital contents are separated. The periorbita is elevated. It's important to keep in mind the bleeders in the orbit at various levels. Laterally, the zygomatico-temporal arteries. Inferiorly, the infraorbital neurovascular bundle. Superomedially, the supraorbital and the supratrochlear neurovascular bundles. It's important to cauterize and cut them. Inferomedially, the lacrimal apparatus is again excised as deep into the lacrimal duct as possible. Once all the contents are freed all around, the orbital contents are amputated with a large Metzenbaum's scissors. That is how the cavity looks at the end of it. We like to debulk as much as possible towards the apex as we can. A good wash of betadine is given. Sometimes I like to leave a Surgicel dipped in amphotericin B at the apex. These are some of the Interop photographs of patients who have undergone exaggeration, and you can see the bony defects. This is the blackening of the bone and the defects in the floor, as well as the medial wall. The medial wall may be surgically created defects during sinus debridements, but the floor and the roof defects are because of the disease per se. So we see the aggressive kind of disease that we see, and this a very typical example of patients with advanced disease who have exaggeration. It's absolutely a bloodless field. It's like a cemented orbit that we see, and really there is hardly any blood loss during surgery. Coming to complications, bleeding, like I said, bleeding is quite minimal, especially when done in patients who have already advanced beyond the orbit. The disease has reached the cranial cavity and the patient is already quite bad. Having said that, a lot of these patients, when had surgery on time, I would say, these patients are on heparin or other antiplatelet agents, and there can be substantial bleeding. So rejecting exaggeration in ROCM, saying that it is going to be bloodless and an easy job, may come as a surprise to a lot of people who don't do it on a regular basis. CSF leaks are, I wouldn't say quite uncommon, but we do see once in a while, and glue comes in handy to plug these. Fistula formation, mainly because of the flap necrosis that we see here in this patient. Flap necrosis, I think I have seen about 80 to 90% of my patients ending up with these kind of flap necrosis and flap defects, which form a fistula between the exterior and the sinus here. Infections are common, and the reason why you see so many fistulae again is because of the generalized hypoxia and ischemia that is prevalent in the upper respiratory system as well as the face region. And the flap that we really are saving up, the skin orbicularis flap, and hoping that it closes the defect like this, like in this patient, beautifully healed skin line socket, you rarely see in patients with mucor. Preoperatively, good pressure dressing. If there is any collection, aspirate on first 2-3 days post-op, and generally at 2 months you see a good well-healed socket like this. Again, like I said, not very common in mucor patients. Prosthetic rehabilitation. Once the patient recovers, once the patient has stopped all the antifungal therapy, generally we wait for at least 6 months before giving prosthesis to these patients. So here is one of my patients who had exaggeration followed by prosthesis, and we were very nicely able to rehabilitate. Another patient with a fistula, with a flap necrosis, but at 6 months you see how nicely it has granulated, giving us a dry area onto which we can fix the prosthesis. Now this process is a silicone prosthesis which is glued to the surrounding area around the socket. So having a dry socket is quite important. Now most of these patients are doing nasal douching as advised by the ENT surgeons, and that's why it's hard to find dry sockets. So we have to generally wait for 6 months so that they stop the douching and then advise processes in these patients. With that, I end my talk. Thank you very much.
Next, we'll have Dr. Tarjini speaking about imaging in renorbital cerebral mucormycosis. So, Dr. Tarjini will be doing imaging as well as orbital debridement, which was supposed to be another talk. She will be doing it at the same back to back.
Okay, so thanks Raghu for having me on your course, and it's good to see the couple of you here. So I'll try to do justice to make you understand imaging in mucormycosis. I have no financial disclosures. You might see certain full face photographs of my patients for which we have the consent. So listed on your right hand side are the concepts along which I'm going to talk to you. I'm essentially going to introduce the different areas in the orbit that can get affected by mucormycosis, and how you can exactly pick up the disease in the orbit. So quintessential to mucor is an MRI with contrast. Now why is that? So if you look at this CT scan, okay, these are all scans along the same coronal plane of the same patient. So if you look at the bone window here, you might feel that probably there is soft tissue involvement, probably there is not, maybe just the bone is eaten up over here. But when you look at the soft tissue, you realize that yes, there's definite involvement in the medial orbit. Now take a look at the comparative MRI. It tells you that it's not only the medial orbit, but it's going right across towards the floor of the orbit. And when you add in contrast, it tells you that the whole tissue is brightening up, it's taking up contrast, which means that the tissue is alive, it is not dead. Mucor tends to produce Angio Invasion. It invades the vessels, and due to that, it produces necrosis of whatever tissues are there in the orbit. The fat dies, the soft tissue dies, because there's necrosis, there's no blood supply to that region, right? Now, what are the imaging sequences that you should ask for? So you should always ask for a MRI with contrast with fat saturated sequences. So what do you mean by fat saturation? This is an image which is not fat saturated. You see the fat over here, intraconal, all white and brightened up, right? So you obviously cannot pick up whether there is any contiguous involvement along this ethmoid sinus. But when you suppress the fat, or when you saturate the fat, which means fat becomes black, fat is not visible, now can you start seeing this medial orbital involvement? So that's where fat suppression helps in picking up subtle orbital disease that you might otherwise miss. And subtle mucormycosis becoming aggressive mucormycosis, is just a matter of time. So you're always better off asking for a fat saturated sequence. Now the third part, like I told you earlier, is mucor by itself. Mucorales are known to be angio-invasive, which means they can enter into blood vessels. And when they enter into blood vessels, they obviously produce necrosis, right? They block the vessels. You obviously cannot see contrast. So this is the classic pathognomonic feature of mucor. So you see this is the superior ophthalmic vein over here. And what you're seeing inside it is the surrounding of the vein is all white and sort of taking up contrast, but the lumen, actual lumen of the vein, is infiltrated by the fungal hyphae, and that's why you're seeing it black. So this is angio invasion, and this particular factor of angio invasion can only be picked up if you have a contrast scan. So we've deduced that you need an MRI, you need fat suppressed sequences, and you need contrast enhancement to actually pick up the disease very well. The ideal imaging sequence you should immediately go to when you have a case of mucor is your T1 or T2 fat suppressed contrast enhanced MRI images. both axial as well as coronal, and they'll show you the disease process very well. So just like the SOV is thrombosed over here, SOV has a path from lateral to medial. In the posterior orbit, it's lateral. In the anterior orbit, it's medial. Similarly, the cavernous sinus is also thrombosed over here. You see that black inside, which means there is necrotic tissue inside that area. So the earliest sign, because this is a rhino-orbital disease, is involvement of the nose and is actually the turbinate becoming black. So you see these turbinates, they are all white, isn't it? However, one turbinate, when you see it as black, that is the classic earliest sign of mucormycosis having affected that part of the nose. So a black turbinate sign is one of the early signs to pick up rhino part of the disease. Now, in the orbit, remember that the entry is not always through the sinus. It's not that the nose has to get involved and only then the orbit gets involved. The entry can be through the pterygopalatine fissure as well. And where is the pterygopalatine fissure? At the junction of the lateral wall and the floor. You see this entire track over here. You don't see that track on the other side. So this is pterygopalatine involvement along with orbital involvement, because of which the muscles are thick and bulky and this fat space is obscured. So that's another thing that you want to pick up as far as the orbit is concerned. Now, certain people have asked me that, okay, how do you look for the pterygopalatine fossa involvement? So I have a simple way of doing it. Go to the lower scans, the inferior axial scans, where you're seeing the projection of the nose. At the inferior axial scans, you're going to see the posterolateral wall of the maxillary sinus. And along the posterolateral wall of the maxillary sinus is the pterygopalatine fossa. So I've given a CT scan here for you to understand. So this is the projection of the nose, which tells you that you're about at this level. You obviously are not at the higher level, so you're at the lower level. The maxillary sinus has started. This is the posterolateral wall of the maxillary sinus, and that's the area of the pterygopalatine fossa. So can you see a difference between the right and the left here? The left has this area of contrast enhancement, which is involvement of the pterygopalatine fossa. A little more extensive involvement of the pterygoid muscle and the pterygopalatine fossa with the classic abscess of mucormycosis, which is hyper intense on the outside and iso to hypo intense on the inside. This whole thing is a pocket full of pus and will need to be surgically removed. Right? One more image to show you the pterygopalatine fossa. So the projection of the nose, posterolateral wall, right side, left side. See the difference between the two sides and the involvement on the left side, right? So that's how you pick up pterygopalatine fossa involvement. So this is just a schematic to show you that the orbit can get involved through several routes. One of the routes is pterygopalatine fossa, which is often missed by many clinicians. Now, in mucor, when you have early orbital involvement, you may just see a little thickening of the muscles, as you're seeing on the left side compared to the right side over here, which may slowly progress to a localized abscess. Again, remember the hyper-intense with the hypo-intense inside is classic of an abscess. So this is an early abscess in the medial orbital compartment. And when you have advanced disease, you can have the entire orbit, which is a bag full of pus. So this is the hyper-intense border of the orbit with the hypo-intensity inside and tenting of the globe, or a guitar pick sign. The pick of the guitar is shaped like this. So when the posterior coats of the orbit are tented, you actually know that the entire orbit is a bag full of pus which is compressing on the eyeball, and hence this is an orbit which cannot be salvaged. Another image of that, so you see these muscles are bright on the normal side, but the muscles are absolutely dead on the other side. And you have this large pocket of abscess that would need to be taken care of. You can also have involvement around the nerve sheath. So you're seeing involvement around the nerve on the right side. On the left side, the nerve is okay. If you want to know whether the nerve is ischemic or not, you would have to go for a diffusion weighted imaging. And when you have restricted diffusion, see the normal side, the nerve is highlighting. See the affected side, the nerve is not highlighting. That tells you the nerve is ischemic. The nerve is about to be dead at any point of time, and you can actually correlate with vision in such patients. So if you have a nerve which is nicely lighting up and there is no diffusion restriction, you should go all guns blazing to salvage that eye. If you have ischemia of the optic nerve already, you may not have to be so aggressive in orbital management. This is another patient with perioptic nerve involvement, and you can see that better on the coronal scan, where all around the nerve you see enhancement. Quickly moving to the last few slides, this is apex involvement. So this is the normal side. See, the apex is nice. Here the apex is involved. You see this white area of involvement all around. You can also see it on coronal, most posterior coronal cuts. Another scan again to show you orbital apex involvement, which is continuing towards the cavernous sinus. Now, when do you say that the cavernous sinus is involved? You say the cavernous sinus is involved when the concavity of the cavernous sinus is lost. Ideally, the cavernous sinus should have a concavity or it should be straight. So if it's lost the concavity, then it's known as cavernous sinus involvement, which is seen on apical cuts. Again, concavity lost and it's convex here, and you see the obvious involvement and the contrast uptake in the cavernous sinus. Cerebral involvement, most of the times we are not the experts to manage this, but early involvement is seen as leptomeningeal enhancement, which you're seeing over here. And then slowly progressive orbital involvement includes formation of an abscess. Again, the same concept, hyper outside, iso to hypo inside, suggesting an abscess in the brain. Same kind of an abscess here in another patient in the frontal lobe of the brain. So you can, this is some resource material that you can go through in case you're interested in studying imaging in mucormycosis in a greater depth. Raghu, can I go ahead with the debridement? Okay, so Namrata spoke about exaggeration in mucormycosis, and there's also another smaller surgical modality which is localized orbital debridement. So exaggeration is the most advanced form of debridement where you're removing everything. You can have a little more localized orbital debridement for certain patients who do not have severe involvement in the orbit. So I'm going to show you a couple of cases. Here is a 47-year-old gentleman who's a known diabetic. He was well controlled with whatever anti-diabetic treatment that he was using. HbA1c slightly on the higher side, but tested positive for COVID, required admission for dropping saturation, CORADS high, CT severity score high, treated with IVMP because of the high CORADS and CT severity score, and then discharged in 2 weeks. However, after his discharge, he developed dental pain, right, on the right side. And then he had a consult for that dental pain, and he had imaging which suggested that he has sinus involvement and rhino-orbital mucormycosis, for which he's undergone sinus debridements. But his ocular complaints continued. So only sinus debridement was done, nothing was done for the orbit. So let me show you certain scans of his. So you are seeing over here a scan which is showing you what? Post-debridement status, half of the turbinates have been eaten up over here, some part of the nasal septum eaten up, and you're seeing this obvious involvement in the right orbit, not in the left orbit, where you see this extraconal involvement slowly going on towards the intraconal. But look at this. This is an hyper-intense area with hypo-intensity inside, which is a small abscess which is lurking there. So even though the eye is white, this orbit is definitely involved with mucormycosis. So he had a repeat sinus debridement. You're seeing more extent of debridement here towards the pterygopalatine fossa. They've eaten up some more tissue. However, that little abscess continued to be there. That was never addressed. And then we went ahead and did an orbital debridement for him. We removed everything from there, and you can see that the floor and all those tissues. Let me just play that again. So I'm not doing very well considering that we have limited time. Okay. So here you can see that the orbit looks much larger compared to this, right? That's because we've decompressed the floor. We've removed the floor and the medial wall. We've debrided all that necrotic tissue from that area. We've given the orbit more space to breathe, and we've removed dead tissue. Any black area on MRI suggests that it is dead tissue. No amount of IV amphotericin B, injection of amphotericin B behind the eye is going to affect dead tissue. Dead tissue needs to be removed. It's very similar to the surgical principle of gangrene elsewhere in the body, where you actually go ahead and remove or amputate the dead part, right? So this is his 2 months follow-up, and though the straight gaze picture does not show you, the birds will show you that he had this proptosis from the orbital involvement, and that proptosis has resolved after the localized debridement that we've done for him. So you can have a quiet eye, but you can have a small abscess lurking inside, and hence reading the MRI correctly is very important. My slides are not advancing, okay. And that's why, again, the role of fat suppression that I told you earlier. So if you have this kind of an image where you don't have fat suppressed sequences, you'll not be able to pick up that abscess. When you suppress the fat, you can now figure out that this is the area where you have a localized abscess, and hence contrast, enhanced, fat suppressed T1 or T2 images are your images of choice in patients with mucormycosis when they have limited disease and you're considering debridement. So I just wanted to highlight few other cases. So this is a patient who, same patient, subsequent scans, where you see that there is progressive involvement of the zygoma, and there is actually a necrotic area developing within the zygoma. And these are patients that should not be left with this kind of osteomyelitis. This is inside the bone. That part needs to be treated. You need to remove the bone. This is one more example of a patient where the frontal bone is involved. You're seeing that he has some amount of ophthalmoplegia, which completely reversed following debridement and removal of that bone. I'll show you some CT scan images which will help you understand what exactly happens. So at presentation, this is the same patient that you saw earlier. There was no bone involvement. But over the course of the disease, you can see that the inner and the outer table both have got involved now. And that's the frontal bone that we removed, preserving the dura. And then following this, he had complete recovery. Just the last case that I want to show, this is a gentleman, a very sad story of a 30-year-old who went for his wife's delivery and the entire family turned positive. His father died of COVID and he developed mucormycosis, and he was 20/20 at presentation. I don't know if that's clearly visible over here, but with a little bit of proptosis and medial orbital involvement. This was not treated given the stigma the family was going through. He started developing lateral rectus paralysis. As you're seeing over here, there was no movement laterally. And you can see that the orbital involvement is increasing with this localized black area telling you that that is dead tissue which needs to be removed. Slowly, he developed complete ophthalmoplegia, went to counting finger vision, and he was advised an exenteration because of the risk that now the disease is going towards the cerebral, towards the brain, and if it goes to the brain, mortality rate is very high. So you can understand the pressure situation that he was in, having lost so many lives. But we persisted, we continued to do debridement for him. These are his post-op images where you can see that the amount of involvement is slowly reducing over a period of time. His clinical improvement is better, and at 6 months, he is actually 20/20 again. So the ophthalmoplegia has reversed and his vision is maintained. This is his last scan. So you might see some amount of residual disease radiologically, but you have to consider both the clinical picture as well as radiological picture to make your decision. So this is a patient who we brought back to 2020, did not have to exenterate, and today this was April when he had the disease. He's completed 1 year, there's no mortality. So I'll just go through briefly our experience of 30 cases that we've done debridement for. The mean age of these patients was around 47, nearly 70% for post-COVID and diabetic, with a large majority presenting with loss of vision. 20% had no PL light, but 40% had vision more than 20/30. And these were all cases where an opinion for exenteration was already made for these patients, but we did not exenterate. We debrided the orbit not once, but multiple times, injected retrobulbar amphotericin B as well, following debridement. And at a mean follow-up of about 30 weeks, which is just over 6 months, 6 to 7 months, we saw an improvement in 95% with stability in 5%. None of the patients worsened, nobody died. So that's the message that I sort of wanted to give, that if you can read the MRI very well and you know which areas are necrotic and if they are amenable to surgical debridement, then that's the modality you need to sort of go for, along with retrobulbar amphotericin B. If you're very confident that the cerebral disease, if there is any, is being taken care by IV amphotericin B. Thank you so much.
Now I would like to invite Dr. HEGDE, Dr. RAGHURAJ, for giving his talk on multidisciplinary management of COVID-19 associated mucormycosis, taking it to the next level.
Good morning. So I'll be speaking about the multidisciplinary management. All my previous speakers have made my job a little easier. So basically multidisciplinary management, it's possible in multispecialty hospitals, and it's all a teamwork. So in our hospital we had a mucor team. So it was a mucor team, and there was very good exchange of information from each of the departments. So this is very critical to take decisions at a very fast pace, because mucormycosis was very, we had to think on our feet and go ahead and take decisions. And sometimes decisions we had to take, very difficult decisions, which we did not want to take, but we were forced to because of the circumstances at that time. So starting from first principles, there is a global guideline for the diagnosis management. This is by the consortium, by the European consortium of infectious disease specialists. So the main gist of it is that we start with the surgical management with ENT and opthal most of the time, and sometimes plastic surgery and sometimes neurosurgery or maxillofacial surgery is involved. Along with that, medical management is also of critical importance, because they have to manage the medical part of the disease, that is the milieu where the fungus takes root, and which is the root cause of the mucormycosis infection that has taken root in the patient. But that doesn't end the story. In the end, we have to do the rehabilitation as well. That includes a very painful and long process, that is with the diet and nutrition and multiple reconstructions involving multiple disciplines. And then finally, in some patients, we have to do some prosthetic rehabilitation as well, because they have to get back to society, and people with without a maxilla, without teeth, without an eye, they find it very difficult to face other people and get back to society and to the normal regular society. So it is important that we rehabilitate them once they are cured of the disease, because that is not the our endpoint is not to cure of the disease, but also to get them back to society. So starting with radiology, it's, already Tarjani's gone through the most important. So investigation of choice is always MRI. With contrast. It's important to have the contrast, because then we'll know where the necrosis is, where the angio invasion is. And if the patient is in ICU, and sometimes these patients are non-cooperative because of their multiple diseases, and in some cases financial problems as well. So in these, we may sometimes have to do a CTPNS and make do with it. And we can sometimes also, because if you want to screen somebody for mucormycosis, we can do a CT scan, quick CT scan, which will be fast enough to, especially in patients with ARDS who are already going for a pulmonary CT. It's easy to do a head CT as well along with the lung CT. So the main image that we have to see is the T1 weighted fat saturation with TSC post contrast. This is where we get the most information from in a mucormycosis patient. So it's also important to choose the right imaging. In this patient is very mild. This is a post kidney transplant patient. So very mild orbital cellulitis. He just presented with that. And when we did the CT scan was ordered outside. So when we did the CT scan, we saw that there's just a mild sinusitis, and didn't look like there was a lot of orbit involvement also. It looked like just a reactive cellulitis. But when we did the MRI, we saw that there is active orbital involvement, including there is enhancement of the medial rectus and the superior rectus, and the sinuses were involved, including there is a necrosis right at the where it's not enhancing, somewhere in the So in the ethmoid sinus, there is a necrosis there, which indicates that it is mucormycosis, and we could go ahead and do an early intervention, because we were able to do the MRI in time. So surgical management, early intervention, surgical intervention has this is what we have learned over the past 1 year, that early surgical intervention will save eyes and also morbidity and life. So preferably we operate with the ENT surgeon, the rhinologist, and the oculoplastic surgeon operate together, and depending on what is required, we do the necessary interventions. And like Namrata also said, no PLI is not an indication for exenteration, so we don't always go for exenteration as the. So even if the patient is not seeing from that eye, just having the globe is important. And extraocular movements is more sensitive than actually the vision as such, because that indicates involvement of the extraocular muscles. So that will give us better, better idea of a prognosis. So the three main goals of the surgical part of the treatment is the disease clearance. We should clear the disease of, because if we don't clear the disease, then then the medicines will not act, because it's an angio invasive disease. So the whatever drugs that we're giving, it will not reach the nidus of the infection. So then histopathology and microbial study is important, so that medical treatment can be instituted, and sometimes sensitivity and fungal culture also is important. What we do as a orbit surgeon, the three main interventions is transcutaneous retroorbital amphotericin B, which Dr. Akshay will be speaking next after me, and orbitotomy and debridement, the limited orbitotomy and debridement, which already Dr. Tarjani has spoken already, and then exaggeration, which Dr. Namrata has already told. So the orbitotomy and debridement gives a midway between the tram, which is the lowest intervention, and as well as the exaggeration, which is the extreme kind of intervention. So, and the exploratory orbitotomy can be done both for saving vision as well as saving the globe. So it doesn't necessarily mean that if the eye is not seeing, we should go ahead with the exaggeration. So multiple papers have come out, and then we see why it is there was such a big surge of mucormycosis after COVID. They've seen that the SARS-CoV-2 virus infects directly the acinar cells of the pancreas, and that can cause cell death and increase proliferation in the neighboring non-infected B cells, and also can cause impaired insulin production, and B cell differentiation also can occur. This causes hyperglycemia, which is not with the patient is not able to tolerate, and then the diabetic ketoacidosis sets in, which sets in the fertile grounds for the mucor to go. So in this setting, an endocrinologist as in the part of the team is a very important. Also, it is important to note that many of these patients also are diabetics from a long time, and they also have chronic kidney disease as well. So nephrologist also is important, because we have to not just manage the patient with the surgical disease and everything, because we also have to manage their kidneys, because amphotericin B is a nephrotoxic drug, and then on top of that, their kidneys are not functioning well, and then there will be electrolyte imbalance, as well as their diabetes is very high. So I mean, the hyperglycemia is uncontrolled hyperglycemia is there. So we all have to work in tandem, because just the surgery will not get rid of the patient. The patient will not get rid of this disease just with surgery. So we start them off on a very high dose IV monotherapy with amphotericin B. Then we move on to a dual therapy after we have some degree of control. And then for many months after this intensive therapy, we wean them off the therapy with the oral posaconazole for sometimes up to 6 to 8 months. There are some other alternative antifungals which we personally, I just came to know all these only once this epidemic had started, that there were other alternatives to mucormycosis. Isoconazole was very helpful in patients who were post-kidney transplant, as well as chronic CKD patients. And posaconazole is not a good standalone drug, but it proved useful when we had acute shortage of amphotericin B. So the pathology and microbiology teams were the back end. They were the back end, and they were working very hard to get us the diagnosis as soon as possible. Initially, when we first had the first cases, it was taking up to a week to get a histopathological diagnosis. But they were communicating with us and told us to get nasal scraping so that they could get the diagnosis in, because if we do a swab or any other, say, we will not get the hyphae, because the hyphae gets broken. So nasal scrapings is the way to get the diagnosis very fast. So we were getting it within 24 hours. And along with that, RT-PCR and histopathology, all of them were speeded up, and we were getting diagnosis. We were getting a histopathological diagnosis within 2 days, sometimes within a month or so, because they were doing so much of it that they were getting very, very fast with it. And fungal culture also was important. Fungal culture and sensitivity was also important, because then we would know which antifungals would work, and when we could optimize treatment and to patients who were sensitive to certain species of the rhizopus of the mucor fungus. So then also they were also giving us feedback regarding the bacterial infections and superior infections that we were getting, which I will give a few case examples. So the first case that I want to show is a 74-year-old woman who came with COVID-associated mucormycosis. It was diagnosis fairly easy then, but her vision was quite good, about 20/30, and only a mild restriction of in the lateral gaze, and there was no RAPD, and there's no pain on movement either. She had a 7th cranial palsy, and there was a little gingival and palatal discoloration. So then, so initially we went in with the intervention. This is the imaging findings, where we could see that the left maxillary sinus as well as the orbit is involved. And we went in with the to do a FES, and the plastic department did the palate debridement, and I gave the transcutaneous amphotericin B, so that because it was very minimal orbital involvement at that point of time. So post-surgery, because there was a time of acute shortage of amphotericin B, the patient was started on oral posaconazole. And like I mentioned earlier, oral posaconazole doesn't work as well as in a patient with active mucormycosis. So as a monotherapy. So after 3 days, actually it worsened, and there was increase in the orbital involvement as well. And we could see that even though we've cleared the sinuses of the disease, it has spread from the cheek area and the pterygopalatine area into the orbit, and it is increasing. All the muscles are increasing in size compared to the earlier, and then there was this the fungal granulomas forming in the cheek area as well. So then we had no option but to, at that point of time, consider exaggeration and along with the radical surgery, because we were short of amphotericin, so it didn't make sense to do a maxillectomy and not do so then we went ahead and did the maxillectomy as well as an exaggeration. This is another patient who was 72-year-old who was okay. So I think we have another 5 minutes more, so I'll just run through the slides in another minute. And this is another patient where we had to operate, and initially we did limited treatment, and then we had to go through since it was increasing, we had to go to the second surgery, which was a little radical, but we managed to save the orbit because we just did an orbital debridement, and post debridement we did a maxillectomy also, but and then we could rehabilitate him with the processes, and he's waiting for a free flap to be done and reconstruction of the left orbit. He has 20/20 vision. So this is another patient who spent about 45 days in the ICU. He came with COVID-associated mucormycosis. Then he had active COVID at that time, and along with that, he had a pulmonary bacterial infection as well, and the pulmonary reactivation of the TB. So he had like triple lung disease as well as COVID-associated mucormycosis. So he went on to make a miraculous recovery because we intervened at the right time, and he's still on ATT, and he has 20/20 vision, and all his extraocular movements also are intact. So there is other mucormycosis sequelae that can happen, and this is a lateral rectus palsy which was treated with surgery, tramp, and systemic thing, and it was her lateral rectus palsy had recovered. And this is another suppurative osteomyelitis, which was secondary to the mucormycosis, and when we went in for the orbitotomy, we got pus coming in. And this is another case where again we had to do a lot of debridement, and we could save his vision as well as the orbit. Okay, and this some sphenoid abscess, and I think I'll stop at this point because I think it's running out of time, and I'll invite my next speaker, who's Dr. Akshay Nair, to come and speak to.
Thank you. So I'm talking about transcutaneous retrobulbar amphotericin B. So I'll quickly go to the main slide that is of interest. I think given that imaging and exaggeration and debridement have been covered, it is important to us for us to know what route of treatment is indicated in what cases. And I think we can all agree that radiology, especially the loss of contrast enhancement on MRI, cavernous apex involvement, and the cavernous sinus status are important factors that help us figure out whether we need to exenterate or whether we can go ahead with any other indication of treatment. So these are, now say for example, this on the left of the orbit, you can see here that none of the muscles are taking up any contrast in contrast to the other side. So this is a completely infarcted orbit where there is complete loss of contrast enhancement. Here you can see that there is this medial rectus has a sliver of contrast being taken up. So this essentially is a dying muscle. And when we exenterated, you could see that nearly 3/4 of all of that, including the medial rectus here, was had completely necrosed. So this, I think, is the most important slide that I'll just be on for 5 minutes before we wrap up, are basically the radiological features that we see. It's a busy slide, but I'll go over it, try to cover it entirely. These are the radiological features that we see on MRI that help us decide whether we need to exenterate or whether we need to give retrobulbar amphotericin B. So the first thing that we see is subtle enhancement that is adjacent to a sinus. Now here you can see the maxillary sinus's involvement, the extraocular muscle is the inferior rectus is enlarged and contrast enhancement is seen. In this case, you would want to give retrobulbar amphotericin B. The next would be in cases where you see clear contrast enhancement with an increase in size of the muscle adjacent to the sinus. So again here there is very minimal orbital disease. There is contrast enhancement and increase in size of the muscle. The frontal sinus here is more involved, so therefore you can go in and give orbital retrobulbar amphotericin B here. The next thing would be where you see perineuritis, and again the extraocular muscles are showing uptake of contrast. So there is diffuse orbital inflammation, perineuritis, but no, there is apical involvement seen here as well, where you would want to go ahead and give retrobulbar amphotericin B. Now here again, this is another case where you see contrast enhancement of the apex, where you can, the cavernous sinus is not involved, so then this again is an indication for retrobulbar amphotericin B. This is loss of contrast enhancement at the apex. Now here you can see, again this would be an indication for you to go ahead and give retrobulbar amphotericin B. Here you can see complete distorted globe where none of the muscles are showing any contrast enhancement. In this case, you would not go ahead with retrobulbar amphotericin B. It's important to know that the clinical presentation, which is ptosis, frozen globe, chemosis, proptosis, are similar across all the entire spectrum. So clinically alone, to be able to say whether this is stage 3A, 3B, 4A, 4B as per all the unvalidated classification systems is very difficult for you to decide which patient needs to be exenterated or which patient needs to get retrobulbar amphotericin B. In this case, with gross distortion of the globe, optic nerve stretch, and complete loss of contrast enhancement of the extraocular muscles, it is a candidate for exenteration. Now, this would be a patient where you can see limited orbital disease. This is one of the patients that RAGHURAJ was mentioning. Is one of the is a sequelae where post-aggressive initial treatment, the patient is on posaconazole, but about 3 months later comes back and you still see some residual disease in the orbit. Here, the patient is more amenable for an orbital debridement. And finally, here the guitar pluck sign. Again, there is complete distortion of architecture of structures in the orbit. This is a case for a clear orbital exaggeration. So, again, this is perineuritis with no appreciable orbital structures involved. Now, if you see even in the coronal structure slice, you can't even identify the extraocular muscles over here. That is completely necrosed, and therefore this and we are surprised to see contrast being taken up in the optic nerve sheath, because you would have expected that also not to show up given the necrosis happening there. Again, this is globe distortion with intraconal abscess, which perineuritis with intraconal abscess, where orbital exaggeration is indicated. So what is the evidence? It comes basically from case reports that initially started to treat mucormycosis. Finally, we had a case in early 2020 where COVID-related mucormycosis was treated with atrobulbar amphotericin B. And also there's a lot of evidence in aspergillosis where this was used, and using that evidence, we used it in mucormycosis. This was a case of a patient who was actually not COVID-related, mucormycosis, who had previously undergone an ENT surgery for mucormycosis. Right eye was no PL, left eye 624, presented with both eyes frozen globe. This was the imaging. You could see that patient has CT scan was really not very helpful. So we did an MRI. You could see both sides showed enlargement of extraocular muscles and disease present in the residual sinus structures as well as the orbits. So patient again was debrided. There was systemic amphotericin B given, and tram was given in both eyes with the hopes of saving the orbit. Here you can see contrast uptake is there. So this is 3.5 mg per ml being diluted, and then after antecedent local anesthesia, you inject into the quadrant which is involved. You can also spread it over 2 or 3 sites based on the amount of inflammation that you see on MRI. The patient underwent 3 injections on alternate days, and at the end, the patient could recover completely from the frozen globe and ptosis that the patient had, and the 624 vision remained. So it's important to monitor these patients. You have to remember the dilution and the site of injection based on MRI. So to summarize, I think imaging and clinical information will guide which patient needs which mode of treatment. TRAMB alone is not the be-all and end-all. TRAMB goes hand in hand with systemic therapy, systemic amphotericin B, control of systemic disorders and comorbidities, and diabetes control. Caution before deciding which patient needs to go TRAMB, go for TRAMB. TRAMB is not for every case, even where the cavernous sinus is involved. Repeat imaging should be done at 4 weeks to be able to understand what was the response of the therapy that was given. Thank you.
Thank you for everyone. So since we've run out of time, and I think we are seeing the next session speakers already here, we can take any questions at the back of the room if anyone